We'll see how that goes. But the first session, I just want to run through a couple of things with you. One about the background, about SNOMED, and about SNOMED International, so where we sit. A bit about why SNOMED. The question which always comes up, which is the bit about, so if you're talking about clinical terminology, you're talking about classification, why do you need both, and what on earth is the difference? So I'll run through a bit of that with you. And then I'll run through a bit about the SNOMED CT features, so almost like SNOMED in a nutshell. So all the basic things we'll cover, and then hopefully the rest of the day will make more sense. At least that's the theory. So background. So SNOMED CT, what is it? Well, it's the biggest clinical terminology in the world. It's set up in terms of being a multi-language clinical terminology. So the initial international release is in US English. Don't get me started. There is a difference between UK English and US English, and we're not going to go there, right? This is not the United Nations. But there is a difference. But the international release is in international English. But then with implementations in different countries, SNOMED facilitates the availability of descriptions in your own language. So yeah, we'll be working with Mail and Elizabeth and other countries which use French to actually provide SNOMED in French. A bit about the history. So where on earth did it come from? It actually, so although this slide says 2002, it started back in the mid-90s with really a joint collaboration between the College of American Pathologists in the US and my neck of the woods, so the NHS in the UK. And it brought together some of the earlier versions of SNOMED. So there's SNOMED 2, SNOMED 3, SNOMED RT, which is SNOMED reference terminology. All of those were brought together with Clinical Terms version 3, which was more a terminology focused on primary care in the UK. Put them together and out popped SNOMED CT. It was managed managed by CAP for a number of years, but then in 2007, a decision was made to transfer all of the IP, so all of the kind of copyright, all the intellectual property, went over to an organisation called the IHCSDO. And the IHCSDO is the International Healthcare Terminology Standards Development Organisation, which is one of the reasons why in 2017 we adopted the name SNOMED International, because nobody could remember what IHCSDO stood for, and people called it IHCSDO, ITSIDO, and a whole lot of other stuff. So just in terms of kind of where it came from, so it was developed back in the mid-90s, really when the first release was in 2002, but then it's grown since then. To give you some idea, when we started the IHCSDO back in 2007, there were 8 countries that were part of the organisation. We're now up to, as you'll see on one of the other slides, we're now up to 49 countries. So it's grown substantially over that time. And just so you know who, I had to edit this one, so France is now on the list, you'll be glad to know. But those are all the ones involved. So obviously the countries literally across the world, so North, South America, Europe, Asia, Africa. We have implementations in Africa, but not necessarily countries as members in Africa. But we do have SNOMED implementations in Africa. We have a surprising number of European countries, which is one of my headaches because I cover Europe. So I have a large number. And if you look within the EU at the moment, we're up to 22 countries out of the 27 EU member states, which causes me some challenges. So a bit about, so why SNOMED CT? So this is kind of like a bit of the, I'm trying to think, a bit of the vision about what we intend for SNOMED CT. So the aim is by 2025, which isn't that far away now, that clinical terminologies will be used globally and it'll result in better health, improved patient outcomes, supported by one language of health. The one thing that I always say about this, so there are a couple of things to bear in mind. One, in terms of although you you won't necessarily see it this way. But in terms of COVID helped move the whole digital agenda forward. The importance of healthcare data became very obvious during COVID, and certainly the initial part of COVID, where people were asking, so how many people have COVID? And you couldn't answer the question. You couldn't answer the question at a national level. You certainly couldn't answer the question across a regional level. The other thing about this is one language of health doesn't, I mean, I would like everybody in the world to use SNOMED CT. The reality is that people do use different terminologies, and we'll come on to this when Anne talks about a bit about the interoperability and linking to other standards and mappings and various other things. But the one language of health really is moving SNOMED towards almost being a semantic layer. So everything out there, whatever terminology you use, you should be able to map it to SNOMED, and then that will help support a lot of the work around analytics moving forwards, which we'll come on to in a couple of slides. So why SNOMED? Well, like I say, most people that work in healthcare, so one thing I didn't tell you is I'm a nurse by background, so I have a vested interest in this. Most people that work in healthcare would support better health and improve patient outcomes, because if you don't, I don't know why you're in the business in some ways. But to support that, you need high quality data to do that. That's always been important. It's nothing to do with SNOMED. It's nothing to do with digital health. It's just a fact of life if you deal with clinical practice. If you look at some of the key kind of data quality measures, so if you're a clinician, what do you need to know? Well, you need to have information which is accurate. So the information needs to reflect reality. One of the things that this kind of points out, particularly when we get to classifications and talking about the way classifications work, classifications group things together. So if you're familiar with ICD-10, or some of the WHO ICD classifications, you'll know that within there are what they call grouper terms. So you get things like not elsewhere specified, not elsewhere classified, others specified. If you're a clinician, those are completely useless. So if you're a surgeon in a theatre and you're operating on a person that's in front of you, you are not doing a procedure which is not otherwise specified. You know exactly what you're doing, and you need to reflect exactly what you're doing in the record, both for your sake as a clinician, but also for the patient's sake. You want to be very clear in their record what's been done to them. It needs to be consistent. So, if you follow the patient journey, the patient is not seen by one clinician. That's always been true. It's even more true now. So think of the whole multidisciplinary team. Who's involved in patient care? Well, nurses, doctors, physios, pharmacists, you name it. So having a consistent way of recording the information is really important. It needs to be complete. So if you look at, go in and look at your own record, hopefully you'd want it to be complete. You'd want everything that's happened to you, all the drugs you're on, to be recorded in your record. And it also needs to be timely. So it's no good going in your record now and what happened to you today appears in your record in 6 months' time. Not very useful. So it needs to be timely. So if you can make clinical data interoperable, meaningful, and actionable, that's where SNOMED CT comes in. The interoperable bit is really important. Like I said, it's about the reality, in some ways, the reality of the healthcare landscape. There are different terminologies, there are different classifications, but all of them need to work together. So this is Anne's animation. She goes animation mad. Hang on, give it time, it'll get there. So if you think about what we talk about when we talk about interoperability, the objective is really to deliver the best possible service and make the relevant enhancements to the record. But the prerequisite to that is that the information has to be available and it has to be understandable by clinicians, by humans, but it also has to be understandable by machines, which is where SNOMED comes in and the background to SNOMED about where it fits in. So take an example. Okay, so an intervertebral disc prolapse. Right, I feel for this because I've had one of these. So you've got a problem with your back, right? So your disc basically is bulged out and you've got problems. So dependent on who you talk to, that can be any of those. So if I talk to my family at home, I don't say I've got an intervertebral disc prolapse because they just look at me as if I've got two heads and I have no idea what I'm talking about. I'll talk about having a slip disc, and everybody knows what a slip disc is. But then as you go through all the different clinical specialties, you can talk about anything. So IVDP, right? So if you talk to an orthopedic surgeon, they'll know exactly what you're talking about with IVDP. If you're talking to physios, they'll talk about intervertebral disc extrusions. You might talk about prolapse intervertebral disc. You might talk about intervertebral disc prolapse. So the same words, but in a different order. But all of those mean the same thing to you. But this goes back to the previous slide. If you're talking about making this machine understandable, a machine doesn't understand language, despite the fact AI is coming in. But at the moment, that statement is true. So all of those may have different codes, and that goes back to the interoperability bit. So dependent on the system that is being used at the time, it could be anything. So BA00, 88439, you name it, it could be it. So how does the machine know that all of those different codes mean the same thing? Because, like I say, systems don't speak the same language. So what do you do about it? Well, if you think a logical question to ask if you're running this at a national level or even within a hospital, right? So how many people have had a disc prolapse in a year? Perfectly reasonable question to ask. You'd want to know it from a clinical perspective. You'd also want to know it from a management perspective, so you know what resources are going in. So, to answer that, what codes should I include? Well, you could say, well, okay, I'll include all of those. That might be one solution. But how can you be sure that you include all the cases? So this is one of the challenges with medical language in some ways. If you want to identify all the appendectomies that are done in a particular hospital, there are two ways of doing that. There's kind of like the right way and the wrong way. You could search through all the records for appendectomy, and you're assuming, wrongly, that all the clinicians in your hospital or all those clinicians within your country all record it the same way. I guarantee that will not be the case, right? And anybody that's worked on the clinical side will support that statement because clinicians do what clinicians do. So how can you be sure? Well, you've either got to know all the words that have always been used, which is almost impossible, or you do it a different way. So what about the different way? So you could say, well, okay, how many people in your country have had some kind of back injury? So I'm not just interested in whether it's a disc prolapse, but any kind of back injury. But you need to include all the codes from all the types of back injuries collected by all the systems. I'll tell you, this animation is going to drive me mad by the end of the day. So you need to pass this patient and his health information between hospitals. So forget about almost the different codes in terms of analysis on a bigger scale, but just on a basic level, you want to transfer a patient from hospital A to hospital B. The hospital A uses a code, so it uses PID 001, and you send it to hospital B, and they have no idea what the code is because hospital B doesn't run the same coding system as hospital A. So does IVDP mean the same as prolapse intervertebral disc? Reasonable question. So the way to do that is to standardize the data. So to do that, you need some common language for health, so everybody's speaking the same language. So if you think about this in terms of a picture, so if you were doing this in digital photography, you know what it is. So you can see it on the screen, you can see here, the big red thing is the disc bulging out of your vertebrae, so you know it's a prolapse disc. So what SNOMED does is say, forget about what you call this in terms of slip disc, IVDP, intervertebral disc exclusion, not interested in what the words are. But conceptually, it has a value, and the value is 7358901. Feel free to look it up. So at least then, between all those systems, you know conceptually what it is you're talking about. And that's where SNOMED comes in. SNOMED provides that common linkage. So if you think about this in terms of stakeholders, so like I say, I'm a clinician. In fact, in some ways, I've been all of these, but we'll kind of get onto that as we go along. But as a clinician, what do you need to know if you're a clinician? Well, you obviously, you're looking after patients. So at the very least, you want to record the clinical details using a language which is clinically focused. So you need a language which is very explicit. It's focused around the clinical domain and allows you to be very expressive in terms of what you're doing. You also want to be able to use that data to do other things, right? So, clinicians are forever doing clinical research, but also more importantly, they're using it for decision making. So, patients don't come into hospital. If you come in through an accident emergency department with a label, you've normally got to make some decisions and do some critical thinking to work out what's wrong with the patient, how to treat them. You also want to be able to clinically document things very fast and in an easy and accurate manner. You don't want to be having a system where you're spending a quarter of an hour trying to find out what the right code is, because that will just never work. But also you want the right data to be available at the right time and in the right place, which goes back to one of the earlier slides. So things being available when you need them to be able to treat that patient. So clinicians are involved throughout the patient journey, but you can use a single terminology to do that. So one of the both the benefits and the challenges in some ways of SNOMED is SNOMED covers all of the healthcare journey. So if you're familiar with other clinical terminologies or clinical standards, most of them will have a clinical focus. So which we cover, I think, this afternoon, but we have a collaboration agreement, for example, with LOINC. So LOINC predominantly supports pathology and laboratory medicine. Now that's fine, and it's very useful, and I'm not knocking LOINC at all. LOINC is really useful within the laboratory environment, but the patient journey doesn't start and end in a laboratory. There are other things, right? So the emergency room, there's medical care in primary care, there's surgery, there's rehabilitation, some in hospital, some outside of hospital, where SNOMED covers literally everything. But like I say, that's both good and also a challenge in terms of how you make the system work in the first place, but also how you maintain that system over time. So if you look at electronic health record, so I'm a clinician, and on the screen in front of me is an EHR. And I'm looking at EHR, so I know something about SNOMED. I know it has a load of codes. They're all big, long numbers. And I look at this screen and there's no big, long numbers on there. So how do I know this system is running SNOMED? Because you don't see any codes, and that's deliberate. So one of the reasons that SNOMED is built the way it is The codes themselves don't mean anything in terms of the rest of SNOMED. So if you look at something like ICD-10 and I tell you something is from chapter A, without knowing what that code is, you'll know roughly what clinical area it relates to. And my mind's gone blank because I can't remember what chapter A is, but that statement is true. Because they're what is called codependent hierarchies. So, all the cardiovascular terms will appear in one particular chapter. All the respiratory ones will appear in a different chapter. SNOMED doesn't do that. So the codes themselves are meaningless to you as a human, but they're very meaningful to the computer. So, when you look at a SNOMED system, don't expect to see codes. They won't be there. What is there are meaningful human readable terms. Now, like I said, the international editions are the examples here are in English, but as you go around the world, dependent on what the languages are locally, they could be anything. So they could be Spanish, they could be French, they could be German, Estonian, Lithuanian, Chinese, whatever. So, one here, what you're seeing on screen, so pneumonia, perfectly readable, you know what it is, I know what it is. But behind that, there will be a code which is meaningful to the computer. So how does this all link together? So you have pneumonia. Well, the way that SNOMED is structured, as well as the codes themselves related to pneumonia, it also exists within a hierarchy. So, if you think of a hierarchy of things, so within SNOMED, we use something called ISAs. So what that means is, if you look at the green thing here on the screen, so pneumonia is a type of lung disorder. And that's how we build up the hierarchies. But lung disorder itself is also, it is a type of disease. If you think about going down to that, as well as the ISAs, we also add some other relationships, some other descriptions. So to pneumonia, we allocate a body site, so in this case, a finding site. So if you have pneumonia, the anatomy that's involved in you having a pneumonia will be your lung structure. Right? I defy anybody in the audience or online to tell me that you can have a pneumonia somewhere else. Right? If you want to take up that challenge, be my guest, but you won't be able to. But also lung structure itself is a type of body structure. So the whole thing is linked together. The same with pneumonia. So if you have pneumonia, apart from the fact it's in your lungs, there's also an associated morphology. So pneumonia is a type of inflammation, is a type of consolidation within your lung. But all those together, so that was just the example of pneumonia. But if you think that in terms of the bigger context of everything within healthcare, all have that semantic network of clinical meanings, all linked together. That allows you to do things accurately, consistently when you come to record information. It also, more importantly, helps you to be very flexible in the way you retrieve and reuse the clinical information. So that goes back to one of my, my earlier questions. So if you're looking at, I'll use the example I always use, but if you think about in terms of appendectomy, so you go to hospital and have your appendix taken out. So there are two ways you could search for information related to appendectomy. One is to search for appendectomy and assume that you know every way any clinician's ever recorded appendectomy. The other way of doing it, bearing in mind what I've just showed you on the screen, is to actually say, well, actually, I'll search through all the records for any concept that had a body site of appendix and a method of excision. So if you excise an appendix, forget about what you call it. But if you excise an appendix, you must be doing an appendectomy. Right? If you look up that, and we'll show you how to, as the day progresses, you'll find out that within SNOMED, there are a number of concepts that involve ripping your appendix out, which don't use the word appendectomy. And that this way allows you to be flexible in the way you retrieve it, but also accurate in the way you retrieve all the examples of what you're looking for. So what happens if you're a hospital administrator, which I also used to be in my past life? So if you're an administrator, you want to, you need to ensure that all the services are delivered and they're recorded and reimbursed, because otherwise, as a hospital administrator, your hospital goes bankrupt. So we believe that data collected at the point of care should be the basis for secondary purposes. That's always been the case. It's nothing to do with SNOMED, but just in terms of running a hospital or overseeing health budgets at a national level. That's always been true. You're heavily reliant on what's recorded by clinicians at the point of care, but then you'll be using that data for other purposes. The question is how do you do that? You also want to minimize data redundancy. So where data is collected, you don't want the same data to be collected by different people in different places. One, because it's a waste of resources, so it's a waste of people's time. But also, if people record it in different places, not surprisingly, humans are humans. There will be errors, I guarantee it. So if you're a hospital administrator, so you look at the EHR, you've got patient history, you've got test investigations, diagnosis, procedures, medication. And all of those will fit into SNOMED. They'll all fit into that semantic network, so they'll all fit into the hierarchy. Everything is linked together. And you'll be interested in particular areas within those hierarchies. So you don't see SNOMED and do analysis on the whole of SNOMED. You'll pick particular areas to do that. And some of those then you can take that data out, you can put them in spreadsheets, you can put them in access databases and do what hospital administrators have always done, which is basically generate income one way or the other. So if you're an information analyst, I've also been one of these, what do you want to know? Well, you want to be able to standardize the way you collate data. So the big challenge for information analysts is there's a lot of data. What do you do with it? Because the data is all slightly different. It's different levels of granularity. It's in different formats. So you've got to have a standardized way to collate it. At a very basic level, just to give you information about what diseases and what the mortality is in your country. So any country should be able to tell you, particularly with chronic diseases, how many patients you've got with ischemic heart disease, how many asthmatics you've got, how many patients with heart failure, that kind of thing. Also, as an analyst, you want to be able to provide that statistical information about the frequency of certain diseases and the cause of death. So if you're treating patients with diabetes and suddenly within France in the south, their death rate is 30% higher than it is in the north, you're going to want to know why. Because if you don't, I guarantee the population in the south will be kind of like on social media having a go at you about why you're not doing something about it. You also need to be able to perform analysis and provide insights into the health state of your population for two reasons. One, to actually manage it. The other one, in terms of providing that information upwards, if you like, in terms of the way you allocate resources going forwards and the way you run a health system. So think about this in the same way. So all the hospitals, clinics, whatever within your country, all plug into a central point, into a data register using SNOMED. And you go in and you do some stuff, right? So you do a bit of selective, explorative analysis of data.
Merci beaucoup.
Hello. So you do your analysis, and the analysis, particularly if you're sending it outside the country, and particularly if you're sending it to the WHO, you need to be able to send that data in ICD. So WHO don't use SNOMED, right? And if you want to discuss that over the break, I'll have a long, copious conversation with you about that one. But the reality is, if you're talking about disease rates within a country, all of the countries globally that are signed up to the WHO provide mortality data. That mortality data is in ICD. So, even if you're collecting it in SNOMED, you're going to need to send it out the other end, if you like, in ICD. So, ICD provides you with a number of different ways of doing statistical analysis of that data, particularly to make that data comparable over time. If you're a researcher, which I dabbled in for a while, but not as a full-time job, so as a researcher, you need to identify an effective way just to identify who the patients are going into your clinical trials. So if you're running a trial on a new cancer drug, how do you identify all the patients that would benefit from your drug? You need to selectively query the data to identify who those patients are. Some of that will be down to the level of, well, they have this disease. More so now, particularly as we move into a whole new area. When you look at genomics and precision medicine, it goes beyond just what diagnosis that patient's got. So you might want to look at different phenotypes. You might want to look at their economic status, their social factors. All of that will feed into who fits within that clinical trial. And obviously you need to collate and analyze the data or collect at those various sites. So the same again, so you've got all the points of care, all feeding data into a central point, so a SNOMED-enabled research database. The same, you've got all the the hierarchy, if you like, of SNOMED terms, and out of all of those, there will be certain patients that meet your criteria to go into the clinical trial, and that will give you your cohort to go and do your stuff with, as they say. And then out of that, you'll have obviously the outcomes of the trial will either be positive or negative, depending on what it is. But it'll enable you to then do the analysis and do the research based on that cohort. The key to this, so irrespective of whether you're a clinician, whether you're a hospital administrator, whether you're an analyst, or whether you're a researcher, the real kind of crux of this, not just from a SNOMED point of view, but purely from a practical point of view more than anything else, is that you record the data once. You record the data once, you make sure it's very accurate, and you record it using a terminology, in this case SNOMED, which enables you to use that data many times. The patient, the data will follow the patient, you can add to that data, but you don't record things multiple times. For all the reasons I've said before. So one, just in terms of wasting time, but also humans being humans, you will start getting errors occur if people are doing it multiple times. So what about making data meaningful? So this goes back to when we talked about that slide with all those different things about IVDP and SIBDisc and whatever. So clinical terms need to be meaningful to clinicians with medical knowledge. So if you talk to a clinician will be able to understand what is meant by myocardial infarction. So, I'm, like I said, I'm a nurse, I'm a cardiac trained nurse, if you go way back. So any of my colleagues, when I work clinically, would have told you, if you ask them, so what's a myocardial infarction? Well, it's a type of ischemic heart disease. It involves the necrosis of a myocardial muscle, so part of your muscle dies when it happens. It involves tissue death, which is what the infarct is, and it's located in the myocardium structure. All of that fits into the semantic network, and we'll kind of get onto that about how you essentially model it in SNOMED terms. But also, all those have different descriptions attached to it. So if I talk, I haven't had one of these, I hasten to add, but if I talk to my family and had myocardial infarct, some would understand that, some wouldn't, because some of my family are involved in healthcare, some aren't. But if I told them I had a heart attack, everybody knows what I've got. But also, if you're talking to cardiac clinicians, cardiac clinicians don't talk about myocardial infarction because most of them are bone idle, and I include myself in that. They'll talk about MI, so everybody's had an MI. But also an MI, myocardial infarction, heart attack, it's an infarction of the heart. It's also a cardiac infarction. I thought I'd put this one in. So tell me, is this correct? The French, infarctus du myocarde? Oui. So it might be, it might be in French. I'm proud of myself there. It's really good. But all those different terms can all mean the same thing to a human. But to a computer, the computer doesn't really care what descriptions you've used. All it needs to know is that what you're conceptually talking about is a myocardial infarction. So, the computer, like I say, the computer ignores what the words are essentially, but focuses on what the concept is. So, SNOMED allows you and gives you a way to represent those clinical meanings in a manner that's processable by computers. This is Anne's diagram. The idea of my brain being kind of hardwired with kind of electronics is a bit bizarre, but there we go. But the way we make it machine processable, like I said, we express it through semantic relationships. So, if you look at, if you talk about myocardial infarction, then this goes back to one of my earlier slides. So the way it's modeled in SNOMED, so a myocardial infarction is a type of ischemic heart disease, but it is a type of myocardial necrosis. It has a finding site of myocardium structure. It has an associated morphology of infarct. So, even if you didn't have the words, if I gave you those relationships, you'd know what I was talking about. But also the computer knows what you're talking about, irrespective of whatever word you've used. So why is this useful? Well, it enables you to do effective searches, which I've mentioned before. So rather than searching for myocardial infarction, you could say, well, actually, all I'm interested in is something that is related to the myocardium structure. It has an associated morphology of infarct. Press the button and you'll get a list of everything that's related to myocardial infarction, irrespective of whatever it's called. It also accurately describes the clinical situation. So if you have, a finding site of myocardium structure, you have an associated morphology of infarct, you can only be talking about myocardial infarction. It can't be anything else. It enables you to have quite powerful analytics. So doing this on a screen like this with one concept is one thing. Doing it in a data warehouse with 50 million patients is slightly different. But the same logic follows, irrespective of whether you're talking about one thing or you're talking about 50 million. So it gives you a powerful way of doing analytics. It also enables you, more importantly, from a clinician's perspective, it gives you a way of being very accurate when you come to providing clinical decision support and how you link knowledge databases within EHRs and within clinical systems. So what about making it actionable? Well, analytics, more so now as we move, like I say, as we move forward, particularly into genomics and personalized medicine, this will become more important as we progress through. So patient data goes into an EMR. So, electronic medical record or EHR, electronic health record, whatever you want to call it. But either way, right, it's an electronic record of what's happened to you as a patient. That provides clinical data, and the clinical data will drop into either research or analytics or both. But that analytics then will provide you and extend clinical knowledge. So whatever comes out of the research analytics will feed into knowledge resources. And those resources provide learning, which then inform the clinician. And the trick then, if you like, is that you have a way of providing that new knowledge, if you like, and that learning back to clinicians in the form of clinical decision support to enable them to provide the most up-to-date clinical care for the patient that they're looking after. And so therefore, there's an interaction there between the EMR, the EHR, and the clinician. And ultimately, that provides the support back to the clinical patient, the clinical care back to the patients. One of the examples of that. So if you're a clinician treating a patient, particularly with chronic diseases, there are a lot of diseases now where the treatment is not to cure the disease. Even as clinical care has progressed, we don't know the answer to everything. You can't cure every disease on the planet. What you can do is treat them, but normally treating a patient clinically will involve you and the patient making a decision about what that treatment is. And a common question that the patient will ask the clinician, so the other way around, is, so if I take drug A, is that better than me taking drug B? Now, historically, the way a clinician would answer that question is they'd say, I'll work on it. So I'll get the medical audit department to go and do the analysis, and then when I see you in 3 months' time at your repeat outpatient appointment, I'll give you the answer. If you're a patient, that's not the most optimum way of doing it, and I wouldn't be happy if something was wrong with me waiting for 3 months to find the answer. What this allows you to do, if you do real-time analytics, is to answer that question there and then. So you can have interfaces within the EHR, which will allow you to run very simple queries on the back of SNOMED to look at the cohort of patients that you've seen as a clinician previously and the outcome for that treatment, to be able to answer that question. If you think about the knowledge resource feeding into the population, so that's more about prevention and policy. So it informs the way that health policy is developed and delivered at a national level or regional level, particularly in terms of some of the chronic disease policies that run in most of the developed world at the moment.
I'm sorry, kommenterar det.
I can't love these comments coming out of the mid-air. So SNOMED CT is far more powerful in supporting research analytics just compared to conventional classifications. One, because you can answer those questions a lot of times in real time, rather than going away and doing quite complex analysis using classifications. Which brings us on to this question, which I said at the start. So the question I get asked more than anything else is terminology and classification. So first of all, what on earth is the difference and why do you need both? Well, we'll do a kind of bring you all up to the same level. So classification is developed to summarize data. It's used for statistical reporting, but within a classification, each code belongs to a single category and can only belong to a single category. The coding's performed based on criteria. So it's not just the words, there are definitions related to those words. So coding is quite a complex process that you go through. If you're talking about a terminology, irrespective of whether you're talking about SNOMED or anything else, but just in terms of a general thing, terminology supports clinicians at the point of care. It enables you to record relevant clinical data and clinical detail. The codes can be grouped into multiple categories, so you're not limited to one type. It's an ontology which enables point-of-care queries, population analytics, clinical research, but more importantly, it provides terms used by clinicians. So it should be using clinical language that clinicians understand. And that means all clinicians, all clinical specialties. So we have a laugh with Anna because I normally do this the other way around. But either way, the way I normally describe this is a pyramid. This happens to be a pyramid standing on its head. But essentially, if you think of SNOMED as the top, so think of this as you go down the pyramid, which is upside down. So if you go down, if you start at the top, think in terms of hundreds of thousands of terms. As you get to the middle bit, you've got tens of thousands of terms. And when you get down to the bottom of bit, you've got hundreds of terms, to give you some idea of scale. In terms of the top bit, so the top bit, you're looking at clinical terminologies. So that might be SNOMED, it might be LOINC, it might be MEDRA, it might be Orphanet. And there are multiple others. But they all refer to and support care and treatment of patients. They support research. They support population health, but population health is a bit of a challenge because it kind of sits between this classification and terminology bit, dependent on the way the analysis is done. But if all you're interested in is statistics, then you're into the classification bit in the middle, and that might be the classification of diseases, which is ICD-9, ICD-10. If you're talking about classification of procedures, there's ICD-10 PCS, there's ICHE, which is the World Health Organization classification of procedures, but there are other classifications. So there's ICPC3, the International Classification for Primary Care, ICMP, which is the International Classification of Nursing Practice, and so on and so forth. There's enough acronyms to keep you going for the next millennium. Below it, if you're involved with particularly planning on healthcare delivery at a national level, you also have resource groups, which might be HRGs, DRGs, there's a whole range of those, but they're a way of grouping particular diseases or procedures together in terms of costing purposes. So think about a way a classification works. So forget about clinical, think of just something nice and simple. So I want to talk about fruits, right? Because we're healthy, it's that kind of thing. So if you think about fruits, well, you've got citrus fruits, you've got berries, you've got tropical fruits, you've got nuts, and you've got a group with other things, okay? So think, go down to the supermarket down the road and think about what's on the shelves in front of you. So if you had a classification that said, okay, well, we'll have a fruits by color. So we've got purple fruits, orange fruits, red fruits, and other fruits. And you then have an apple turns up, which is red and green. What do you do with it? Because if it's an apple, going from the previous slide, but it's red and green, then it's a red fruit. But the red fruit are red. They don't have green in it. So what do you do with that? It's a bit of a... So if you think about this in terms of clinical, this is an example from ICD-10. So ICD-10, so chapter 10 or chapter X are diseases of the respiratory system. And under disease of the respiratory system, you've got all the usual suspects. So you've got upper URTIs, so upper respiratory tract infections, influenza, pneumonia. You can read them yourself. And if you were to take one of those, so you look at influenza and pneumonia, you've got a number of different ones there which are very specific. So you've got influenza due to identified seasonal flu, which is really common. And then you've got these kind of group categories. So you've got influenza virus not identified. That one always kind of gets me. So how do you know something's an influenza if you don't know what the virus is? How do you know it's? But anyway, well, we'll leave that aside a minute. But you've got viral pneumonia not elsewhere classified. Oh, what does that mean? So if you're a clinician seeing a patient, you would never record that. If you go down a level below, so viral pneumonia not elsewhere classified includes adenoviral pneumonia, respiratory syncytial virus, parainfluenza, blah, blah, blah. So if you're talking about a reference terminology, which is what SNOMED is, that defines concepts according to their meaning, but it also allows you to use a polyhierarchy. All polyhierarchy means if you look for the hierarchy, there are multiple things above it in the hierarchy. And it allows you to put additional defining characteristics in there. So, fruits, where you can have a citrus fruit and a tropical fruit, but they're all type of fruits. So coconuts, bananas, tropical fruits. Right, oranges, limes, citrus fruits. But oranges and limes are also tropical fruits. So that's just thinking about fruits. If you think about reference terminology, so you want to do the same thing with colours. Well, okay, so if you're talking about bananas that are ripe, so we just ignore the kind of the black bananas going off and the green bananas aren't there yet. But a ripe banana is yellow. So banana might be a tropical fruit, but it also has the colour yellow. The same with limes. So limes are a citrus fruit. They're also a tropical fruit. They also have the colour green. Right, the same with orange. I'm not going to do this for everyone, otherwise we'll be here till Christmas, right? But you can see how this will work. So each of them allows you to provide those linkages, right? The same with coconuts. If you think about then the way that goes forward, so defining concepts according to their meaning, if you do that within, all across the board, that gives you a very powerful linkage between all of those things. They've all got the different types, the different concepts, but they've all got different characteristics, all of which are linked. Bring us back to the real world, if you like, the clinical world for a minute. So you have viral pneumonia, bacterial pneumonia, very common. If you work in most hospitals in the Western Hemisphere, you'll see a lot of these across the time. So viral pneumonia, bacterial pneumonia, type of pneumonia, fairly straightforward. Viral pneumonia also happens to be a viral disease, not surprisingly. The same with bacterial pneumonia, also happens to be a bacterial respiratory infection. But so bacterial respiratory infection is also a type of bacterial infectious disease. It's also a disorder of the respiratory system. But as you go up, all of those, so whether you're talking about viral disease, bacterial infectious disease, it's a type of infectious disease, which is a clinical finding, which is a SNOMED CT concept, if you go right up to the top of the hierarchy. But add to that all those defining characteristics we've talked about. So viral pneumonia will have a finding site of lung structure. It also has an associated morphology of inflammation and consolidation. It also has an infectious process, so it has a pathological process, an infectious process. It also has a causative agent of virus. If those four things are true, you must be talking about viral pneumonia. Equally, if you were to go down the hierarchy and you're identifying specific viruses, so a specific type of viral pneumonia, then the causative agent would relate to the specific virus you're talking about. All of those themselves, so the actual values, are also types of SNOMED CT concept. So if you do analytics, so going back to the ICD-10 and all those groupers, so you take a code J12.9, which is viral pneumonia unspecified. And we go back to those links about what it is within the classification itself. But you're faced as a researcher or as a data analyst with a set of questions. So I want to know, if I'm looking at this patient record, does this patient have a respiratory disorder? Well, because I'm an expert in ICD-10, I know that the answer to that question is yes, because all the J chapters, all the codes within the J chapter of ICD-10 relate to respiratory disorders. So forget about the 12.9. Just the fact that the J's there means that this thing is talking about a respiratory disorder. So a reasonable question, does this patient have an infection? Absolutely no idea whatsoever. Because in ICD-10, all the infections occur in chapter A. But this hasn't got a chapter A. There's no A in J12.9. Some of this relates to the way ICD-10 is built, which is it's a single hierarchy. So if you have something within ICD-10, it can only have one parent. So if you're talking about viral pneumonia, it can either be a respiratory disorder or it could be an infection, but it can't be both. ICD-10 classes it rightly as a respiratory disorder. So does this disorder affect the lung? No idea, because the classification doesn't have that axis. So there's no way of knowing this relates to the lung. Although, as a human, you'd know if you're talking about pneumonia, it must be by default. Is disorder caused by virus? No way of knowing that either, because the classification doesn't tell you that. So think about in terms of now SNOMED. So viral pneumonia, we don't have viral pneumonia unspecified, because SNOMED is developed as a point of care recording for clinicians. So we don't bother with the groupers, because in terms of delivering real care, the groupers are irrelevant. But we do have viral pneumonia disorder, which pulls together within SNOMED any type of viral pneumonia. So if you think of all the things that are below it as children. And within that, I'm just trying to think, it comes up bigger. So within, if you go and look in the browser, which we'll show you later, but it has parent concepts. So viral pneumonia is a type of infective pneumonia. It's also a viral low respiratory infection. So firstly, in SNOMED, it has multiple parents, not single parents. But it also has all that modeling. So it also has pathological process, infectious process, associated morphology, the other four. So think about being in the same position now and asking the same question. So does this patient have a respiratory disorder? Yeah. It's a subtype of respiratory disorder, so it must be true. Does this patient have an infection? Well, yes, because it's also a subtype of infectious disease. So both of those statements must be true. Does this disorder affect the lung? Well, yeah, because it has a finding site of lung structure. Is it caused by a virus? Well, yeah, because it has a causative agent of virus. And equally, like say, if you wanted to be more specific, it could be coronavirus, it could be whatever it is, right? But either way, it has a causative agent of virus. So it allows you to be very specific when you come to doing the analysis. So let's give you a crash course. These are all the things you need to know about SNOMED in a nutshell. So if you've fallen asleep for the first bit, stay awake for this bit. First of all, point you to our browser. So if you go on snomed.org/browser, there is a browser which allows you to look at the international release of SNOMED and also a number of other national extensions. The browser allows you to look up individual concepts, but it also gives you all that detail that I've been talking about. So it will give you all the parents, it will give you the children, and also give you all the relationships. So it allows you to see them. The key components. So SNOMED's made up of 3 main bits, if you like: concepts, descriptions, relationships. We'll come onto the hierarchies and versioning in a minute. In terms of the components, so those are the 3 bits. In terms of concepts, so concepts are just a unique clinical idea, right? So think of this in terms of a computer. So if a computer doesn't need to know the words, it hasn't got the thing in front of it, but it needs to know what you're talking about. You as a clinician, if you like, or you as a human, if I put on, I'll do that. So if I stick that in front of you, you know what it is. But from that distance, you won't know what type of watch it is, who made it, but you know to watch. And you might want to call it, so is it a watch? Is it a quartz watch? Have I got more money than sense? So it's an automatic watch. It could be anything, but it's a watch. So you've got an idea what it is, and you will attach descriptions to that to make sense of it in the real world. So, like I say, unique clinical ideas. So, you might think of cells, you might think of, your aorta, but you'll have something in your head. And to those things, we attach codes, numeric codes. Like I say, they don't relate to where they sit in the hierarchy, but they are unique. To those codes, to make it meaningful, we attach descriptions so people understand what it is. So it might be myocardial infarction, cardiac infarct, heart attack, but we allocate those descriptions and associate them with one particular code. And so those those descriptions, like I say, some of them, if you're looking at the international release, might be in English, but they could be in any language you like. So they could be in Spanish, French, knock yourself out, right? Whatever language you like. We also add within SNOMED, there are relationships, and that's what in terms of the hierarchies, we refer to them as ISAs. But there are other things like associated morphology, finding site, procedure site, whatever. There's a lot of methods, all different types of relationships, and those relationships have values. And that, so a finding site could be cardiac muscle, it could be any anatomy you like. Associated morphology is infarct, but equally it could be any other morphology that we specify within the morphology hierarchy within SNOMED. The way we allocate those relationships, it's not the Wild West. So you can't allocate anything you like to anything else. There are rules. So the rules, the way we specify them is through something we refer to as the concept model. So think of it as a data model. And it essentially gives you a domain, it gives you an attribute, a label, if you like, and then it gives you a range of concepts that you can choose from. So if you're looking at clinical findings, the attribute, if you're talking about anatomy, is finding site. We don't allow you to add a SNOMED value of procedure because it would be meaningless. It would also be silly, but apart from that. So there are rules that are associated with this. And there are rules in terms of the domains, in terms of the range, and also in terms of cardinality. So some things are allowed to have multiple values using the same attribute. Others aren't. So depending on the concepts themselves, there are rules based on the individual concepts. As well as being a concept model that you can read. So going back to the browser, if you go into our browser, there is a machine readable version, but it's also a human readable version that you can look at on the browser and actually look at what this is in real life. So you can look at the individual domains, you can look at what attributes are available for each of those attributes, you can look at the range of values. But we provide a version which is machine readable, which allows you to build that, or system builders to put it into their systems to actually make the systems work. The hierarchies themselves, so there, if you look at SNOMED is basically a hierarchy with the top level concept is something called SNOMED CT concept. So if you follow the hierarchies up, everything eventually will be a type of SNOMED CT concept. But the top level hierarchies, the way we arrange them, are what's in front of you here. So things like body structure, clinical findings, events, organism, pharmaceutical, biologic products and drugs, procedures, you can read them all here. They have a broad scope. So, like I said right at the start, SNOMED covers everything that happens in the clinical space. So, it needs to cover signs, symptoms, test results, observations, medical history, family history, medication, procedures, diagnosis. It covers everything. So versioning and quality assurance. I want to say something about this for two reasons. One is the real world, if you like. So clinical practice evolves very quickly. There are new definitions of diseases, there are new procedures, there are new treatments. Even although it's a surprising statement, there are new definitions of anatomy as we go forward. So things change at a very fast pace. So SNOMED needs to evolve as a terminology. To do that, it has regular updates, but also we have to make sure that there are quality assurance processes involved, right? Because ultimately what you're looking at is delivery of clinical care. What we don't want to do is, we don't want to be in a situation where we made a mistake and it affects a patient ultimately down the line. So how do we do that? Well, one, we've got a team of experienced terminology authors and technical experts that either add the codes to SNOMED or put them all together in terms of the way we technically build the release. We have a collaboration with experts and stakeholders. So one of the challenges with clinical care is the fact that there are multiple specialties. So the WHO define a list of clinical specialties of just over 380 different specialties. If you can name them all, I'm impressed, because I can't, but apparently they all exist. So how do we keep SNOMED up to date? Well, we do that, like I say, through collaboration with experts. We have individual links with subject matter experts globally and with groups globally. In terms of the technical side, well, we have release validation. So SNOMED, the files themselves are very big. To give you some idea, the concept file has about 500,000 concepts in it. The descriptions file has about 1.5 million, and we're up to about 3.5 million with the relationships. So they're very big files. To make sure that we don't make some errors, we have a whole release validation process which checks all the release files before they go out. We also produce a lot of guidance material and a lot of education material around SNOMED. So about the way SNOMED is built, where changes occur in SNOMED, either in terms of the concepts themselves or the hierarchies, we'll look at documenting that. Also, the way SNOMED, the SNOMED release is built, we also have versioning within there. So each release of SNOMED that comes out is allocated a version identifier. So you can go, if you've got nothing better to do, in theory, you could go right back to 2002 from the current release files and rebuild the release that occurred in 2002, because we provide the history as part of the release files. The reason that's important, so in terms of current systems, a clinician delivering healthcare now, who cares? If you're doing analytics over time, so if you would say reviewing all the diabetic treatments and diabetic patients in France over the last 10 years, you'd want to know how that was recorded 10 years ago, and that's different from it is today. So this enables you to do that analysis going backwards over time, particularly over a long period of time. So one of the things I also do within SNOMED, I deal with a lot of the help desk queries. We're getting more and more requests now related to the legal side of this. So where there are medico-legal cases going back 5 years ago, and they're looking through electronic records, and the lawyers involved want to know what the clinician recorded, what the system was 5 years ago. Well, it used SNOMED. Well, yeah, but if you look at the SNOMED browser today, that's not the same as the SNOMED browser 5 years ago. So this enables you to support that use case going forwards. And I'm going to stop there. How are we doing? Pretty good. I'm impressed. My timekeeping's improved. Questions?
Yes. So you made a comparison between SNOMED CT and ICD-10. Yep. So there is a new version now. It's ICD-11. and ICD 11 is proposing still the classification,
Yep.
but also an ontology. So did you study the SNOMED CT versus the new ICD 11 ontology?
There's always one in the audience that has to ask that. Okay, so I'll answer your question, but I'll also put something back to you. So one of the things that I frequently get asked is about ICD 11, and I always come back to you with the same question. So when you talk about ICD 11, what are you talking about? Because there's ICD 11 MMS, which is the updated version of ICD 10, essentially. Then there's ICD 11 foundation layer. Well, ICD foundation layer is essentially, if you want to compare it to SNOMED, it's a big bucket of, and this is WHO's description, not mine. Okay, so ICD 11 foundation is a bucket of terms. Each of those terms is allocated a UID, so each of them has a unique identifier, the same as SNOMED. But in the foundation layer, there is no modeling. So there's no, although all those concepts exist, they've all got individual identifiers. There's no defined data model for the way they're structured. If you then build MMS or you build any of the other linearizations, so it might be the dermatology linearization, primary care linearization, each of those linearizations need to provide their own data model within the linearization to build the hierarchies up. So they are different. If you're looking at MMS, so MMS, the way most countries, certainly in Europe, are looking at this, is to collect data as SNOMED terms, do the analysis in MMS in ICD terms. We're working currently on building the map between SNOMED and ICD-11 MMS, which will allow you to automate the process. What we won't do, well, first of all, what we won't do, but also what we can't do, is essentially build a map between SNOMED and the foundation layer. One, there isn't a clear use case to do it. So one, why would you? Because there isn't a clear use case to do it. But just in technical terms, it's almost impossible to do. So we looked at doing a pilot of essentially looking at what was in the dermatology chapter and mapping to the foundation layer. So if you look at concepts missing from SNOMED, there are about 700 concepts missing from SNOMED. If you look at, not necessarily word for word, but broad concepts in terms of what was in the foundation layer. If you do it the other way around, then the foundation layer was missing 7,500 concepts in dermatology because of the way, and that doesn't mean, it doesn't mean the clinicians that built, the ICD-11 chapter were wrong. It's nothing to do with that, but more to do with the use case about how you build it. There are big differences between those two, but certainly it's not our advice. It's just looking at what people are doing. The most logical one, goes back to one of my earlier slides about this thing about recording it once and then using it for multiple purposes. So record it in SNOMED, do the magic thing through the mapping table, but do the analysis if you want to in ICD-11, and you'll need to transform it into ICD-11 if you're going to share data with the WHO anyway, because the WHO, the mandatory reporting at a national level will be in ICD-11. Does that kind of answer your question? But be careful, because I might give the microphone to you and get you to explain what the foundation layer is.
We also have a question from Julie Nguyen in the chat. You can see.
So, well, there's our answer to that and there's your answer to that, and they're not necessarily the same. So our answer is, so the SNOMED files that we produce internationally, we release and distribute in something called RF2, so release format 2, which is basically a comma delimited file format. You are transforming that and releasing it in OWL. So there's kind of two answers to that question, depending on where you come from.
So we are publishing both format, the RF2 format and the OWL format, because all the other terminologies in the SMT are using this format. And we'll talk a bit later, but we have also a fire terminology service that is going on live. So, and we have also a question from Florence. Where is SNOMED used? I guess it's in France.
Well, yeah, I mean, the answer to that is everywhere. If you mean in France, well, I can give you a list, but in a variety of different settings. So there are some hospitals in France using it. There are vendors using it. It's in primary care systems. It's in clinical prescribing systems. If you want a complete list, I'll run a list of kind of like the licensees for you. But yeah, it's in a lot of places in France. If you mean in terms of the world, so at the moment, there are SNOMED implementations in about 88 countries globally, in all kinds of different settings.
And in terms of use cases in France, but Alain will talk a bit more later, we are using in the context of diseases about anatomy and microorganism. So that's the first use cases in France.